Dr. Xinyuan, she's going to present what is pachychoroid. Please, Xinyuan.
Morning, chairs and everyone. It's my great honor and pleasure to have this opportunity to deliver the invited topic, what is pachychoroid? This is my financial disclosure. My talk today will focus on the discovery of pachychoroid, the diagnostic criteria of pachychoroid and the underlying mechanisms, the research progress and unsolved problems about pachychoroid and pachychoroid spectrum disorders. As a retina specialist, we all be aware of the clinical understanding of fundus diseases is accompanied by the development of ophthalmic imaging. Among all the non-invasive fundus examination tools, OCT has been the fastest advancement in recent years, significantly impacting clinical practice. The innovation and the progression of OCT are the foundation of the discovery and establishment of the concept of pachychoroid. The boundary between the choroid and the sclera has evolved from being invisible by TD and SD OCT to can be shown by EDI OCT, and finally to completely clear due to the upgrade ISS OCT, which has made a significant advancement in depth and detailed visualization of the choroid. First, let's review the anatomy and function of the choroid. The choroidal capillaries, subtle and hallux layers, which among the 5 choroidal layers are indeed rich in blood vessels and play critical roles in supplying nutrients and oxygen to the retina and surrounding tissues. The prefix pachy is derived from the Greek word, which means thickening or hypertrophy. In 2013, Dr. Warrell and Professor Bellefriend were the first to report and describe pachychoroid spectrum disease, thereby confirming the concept of pachychoroid in choroid. In 2017, my team and Dr. Timo Salai introduced the concept in China. Over the 10 years since 2013, although we have a deeper understanding of pachychoroid and pachychoroid spectrum disorders, there are still a lot of unknowns, including the quantitative diagnostic criteria for thickening choroid and underlying mechanisms of pachychoroid and pachychoroid spectrum disorders. First, I would like to discuss the issue of the diagnostic criteria for pachychoroid. Currently, there's no unified international standard for measuring the thickness of the choroid or define the cutoff value of the pachychoroid. For example, for measuring the thickness of the choroid, some studies use a manual management, which can induce management and methodology errors. The OCT machine equipped with the EDTRS-based automated measurement method is currently the most objective measurement technique. By performing 360-degree repeatable subfoveal choroidal thickness measurements, overlaying the data, it provides more accurate results and reduces human error. Secondly, current diagnostic criteria cutoff values for pachychoroid is not objective. Most studies use the average choroidal thickness of the study population, with the standard deviation added or subtracted to determine the value. Some studies directly use the threshold of greater than 228 micrometer as a diagnostic criterion. However, choroidal thickness in healthy individuals varies physiology factors such as time of day, age, and other conditions. Therefore, the cutoff value based on physiological indicators such as age, sex, refractive error, and anterior chamber dips are more reasonable. To answer the clinical questions and establish objective criterion for pachychoroid, we establish a pachychoroid large sample size cohort using a likelihood statistical analysis for the diagnostic cutoff value of pachychoroid. And in this study, we controlled age, gender, diopter, refractive error, and anterior chamber dips as the physiological parameters. An objective diagnostic criterion has been proposed, and its performance was compared with the traditional average value-based standard using ROC curve analysis. The results confirmed that it's more accurate and reliable than the conventional metrics. As you can see, the diagnostic values are determined based on different age groups. Based on this large cohort, we further confirmed that the subfoveal choroid thickness was negatively correlated with age in healthy males and females and has a weak positive correlation with the increase of diopter. We also found that about 20% of eyes with neovascular AMD and 40% of eyes with PCV with non-pachychoroid. FFCT in the CSC group is higher than that in the neovascular AMD, PCV, and normal control. FFCT in the Pachy PCV groups is higher than that in the non-Pachy PCV and the normal control group. Similarity in the Pachy and non-Pachy neovascular AMD group. To further answer the clinical questions, is PCV is a subtype of neovascular AMD, and what the underlying mechanism of PCV and neovascular AMD? We further investigate the blood flow in the CC hallux and Satus layers. The multivariable logistic models found that after controlling for age, 6, and diopter, the blood flow in the CC and hallux layer in the Pachy and non-Pachy AMD, PCV, and CSC group is significantly higher than that in the normal group. But for the Satus layer, the blood flow in the Satus layer has no difference in the CSC and the normal groups. But the PCV and the neovascular AMD groups is significantly lower than that in the normal group. Why only Satus layer in CSC does not decrease? Is age related to blood flow in different pachychoroidal diseases phenotypes? To answer these questions, we looked back for the baseline characters. We found that the gender and refractive error or other parameters can be matched. Only age cannot be matched between the CSC and the PCV and the neovascular AMD group. Patient in the CSC group is much younger than that two groups. We further found that among all the age-related microvascular dysfunction factors, collateral circulation is the primary risk factor as agent leads to a decrease in the number, diameter, and the tortuosity of collateral vessels. From our next study, we found that CSC poses the majority of diffuse choroidal capillary circulation. PCV poses the majority of local CC type, and no CC was found mostly in normal subjects, indicating that the decreased compensatory ability of collateral circulation and choroidal blood vessel remodeling contribute to the phenotype of the different in the pachychoroidal patients. Furthermore, we identified the role of dyslipidemia in the pathogenesis of pachychoroidal diseases, identifying some new biomarkers, including the ratio of LDL-C to HDL-C, as well as HCY, are differentially regulated in PCV and neovascular AMD. We also identified the RCT pathway and the LXR agonists that contribute to the pathogenesis of pachychoroidal diseases. Furthermore, we also found that genetic polymorphisms, lipid metabolism pathway also differentially regulated in the pathogenesis of PCV and neovascular AMD. Our team is also using AI to further investigate the clinical phenotype difference between different phenotypes of pachychoroidal diseases. Till now, we have published several manuscripts, and research is still going on. Okay, so take-home messages. The diagnostic criteria for pachychoroid remain poorly defined. Our team developed objective criteria integrating demographic and clinical factors, including age, sex, refractive error, anterior chamber depth. So thick choroidal can also exist in healthy individuals, requiring comprehensive imaging evidence for PCD diagnosis. PCD has a diverse causes. Our work focuses on the role of the lipid metabolism pathway in the pathogenesis of PCD. Also, AI-based tools show potential for improving PCD diagnosis and prognosis. Finally, I just wanted to emphasize that we have entered the era of molecular imaging. We are looking forward to more groundbreaking advancement for deeper understanding the underlying mechanisms of pachychoroid and pachychoroid spectrum disorders. Thanks to our collaborators and our team collaborators. Thank you for your listening.
Thank you. Well, Xinyuan, are you there? Are you there at the Zoom?
Yes, hi, Person.
Oh, hi.
Yes.
Hi, nice
Hi,
meeting you.
Person.
Hi,
Nice to meet you.
Yeah,
Person.
great
Hi,
talk.
Nat. Thank you.
Great talk. Well, may I ask the audience first, do you have any question for Xinyuan? She's in the Zoom, so we can talk with her. Well, may I ask you a question, Xinyuan?
Yes.
Well,
yes.
how you diagnose pachychoroid in myopic eyes? For those with...
Good question.
Yeah.
Yeah, you're right. Because I think that the thickness of the choroid decreased with the diopter, and for the high myopia patient, seems to have a thick, much thinner choroidal thickness than the normal person. So after we adjust with the diopter, the cutoff value of different age for the pachychoroid is quite different from the healthy eyes. So we have diagnostic criteria and use the multivariable method, logistic method to determine the cutoff value for the high myopia patients.
I see.
So the diagnosis cutoff value is quite different from the healthy person or the other, or without the high myopia patients.
Okay, great.
Quick question, Xinyuan. Great talk.
Thank you.
I just want to know if you have any markers or triggers. We often seen that there's a lot of choroidal remodeling happening. So,
Yeah.
and we also see that in some patients, in the same patient, you have PCV and sometimes CSCR in the other eye, or over time develop PCV morphing into a CSCR like picture, or vice versa. From your large and impressive, data set with pachychoroid, have you at all identified any markers which suggest that there might be a movement from one pathology to the other?
Great question. Yeah, we in our large cohort, we made some patients, for example, some chronic CSC patient developed to PCV. We pick up some imaging biomarkers. For example, the double layer SAN for the highest of the double layer SAN, or the timing for the resolve of the subretinal fluid may be useful marker for the progression to PCV for the CSC patient. Some markers we are still studying. Very good question.
You have a question? Yeah, please.
Yeah, one more.
Yeah, I have a question related to myopia. In continuation to the question first asked, there is a choroidal thinning in myopia, if I'm correct. And the therapies that are given for myopia correction, for axial length correction, like atropine, cause choroidal thickening. So how do you differentiate between pachychoroid and the treatment-related thickness of the choroid?
I'm sorry, how can I differentiate
between pachychoroid and the treatment-related thickening of the choroid?
The thickening of the choroidal thickness, you mean? I can't hear clearly.
During atropine treatment leads to choroidal thickening.
So,
that's a very good
he's
question.
asking that when you treat a myope with atropine, the choroid can thicken. So he's asking how that interferes with your assessment of the presence of pachychoroid in that setting.
Yeah, this question actually related to the criterion for pachychoroid diseases. Actually, for pachychoroid diseases, we should identify that the pachychoroid is a chronic thickening of the choroid, and you should identify the diffuse choroidal leaking, so we can, diagnose the pachychoroidal disorders. So I think that question related to the criterion about the pachychoroidal diseases.